yeah, thank
And
you, Rachel. Rachel will help us in the sharing the poll questions. Do you need the poll questions now, Professor Mark?
Yeah,
so
I have them.
A speaker doesn't need a lot of introduction. He the pioneer in the Project ECO and also mentoring African colleagues, and has a lot of experience in endoscopy, teaching, RCP, EUS, and he knows our also problems. That's why he want to choose esophageal and gastric varices combined, and how to manage this perspective. So the floor is yours, Professor Mark. And Alina will help us in the sharing the poll questions. Do you need it now?
Yeah, and actually, I think I will share them. Alina and I discuss. Okay. Welcome, everyone. We're going to start with this. This is the case for today. It's the case that prompted this presentation. So there's only one poll question. I apologize to those of you who aren't GI endoscopists. This may not be, you may not be so interested in the answer, but I'll read it out to you. You perform endoscopy on a patient with recent GI hemorrhage. There are large esophageal varices with red signs. They extend onto the gastric lesser curvature and are large, over 10 millimeters in the stomach also. You cannot be sure which varix bled. What endoscopic intervention would you do during the initial endoscopy? So these are the choices. You can say, I will do no intervention, band ligation of the esophagus varices only, cyanoacrylate injection of the gastric varices only, or both, cyanoacrylate injection of the gastric varices, and I will band ligate the esophagus varices at the same time. Or maybe you have some other idea or you're not sure. So please take a vote.
Yeah. Prof, do you want to put it in the chat box or in the...
Oh, I'm sorry. Was it not visible to you?
Yes, it's visible. Okay, it's visible now. Yeah.
Okay, there are more than 7 of you, so everyone needs to vote on this. Amir is excused. Although, Amir, if you have an opinion, you're free to vote. Okay, so I will say that this is very interesting because we had this exact case 2 weeks ago in the St. Paul's Hospital endoscopy unit. And there was disagreement in the room, in the endoscopy room, about what to do. One colleague said, we should do nothing. They're large gastric varices. Let's just think of some other solution. The patient, as it turns out, probably has schistosomiasis as the cause of his portal hypertension. So he has a relatively normal liver, and maybe he should have surgery for his varices rather than endoscopy. Another colleague said, no, we should be band ligating these varices. And another said, well, we don't have cyanoacrylate in the unit, but they said, well, we should send him for cyanoacrylate injection. That's the first thing. So there were a variety of opinions about what to do. And ultimately, at my behest, we band ligated the esophageal varices. So I'm in the minority in this group today about what to do. But what I want to do today is can you all see the results, by the way? Yeah, okay. So what I hope to do today is sort of review the literature about this, what we know, and also what is new. So I'm going to try and share my screen here. Let's see if I can get a slideshow. Play from the start. Can you see my screen now, everyone? Carlos, can you hear me?
Carlos, yes, Prof. Yes, it is audible.
All right. So this is the case. I already showed it to you, and I asked you what you would do, and we have a wide range of opinions here. The majority was to inject cyanoacrylate in the gastric varices and to band ligate the esophageal varices at the same time. That was 69%. 25% would do what I did, which was just to band ligate the esophagus varices. I have to say we did not have any cyanoacrylate. And one person said they would just treat the gastric varix only. So I want you to note, looking at the case, that there are large esophageal varices with red signs, high risk, and they extend onto the gastric lesser curvature. And the fact they're on the lesser curvature turns out to matter as we go along here. So what do we know about the natural history of coexisting esophageal and gastric varices? Well, this is the most important paper, and it was published by Dr. Sub-saharan in 1992. So how often do you cite a paper from 1992? Not very often. But this remains the landmark study in this topic. And this was done in New Delhi, India, from a place that at that time was very much a limited resource setting. And it remains sort of the landmark paper. It was an observational study of 568 patients with portal hypertension. About only a little over half had cirrhosis, by the way. The rest had other causes of non-cirrhotic portal hypertension. But the majority had a history of bleeding. And in this study, gastric varices were defined as primary if they were present at the initial endoscopy, and secondary if they developed during follow-up. So it's from this paper that we get this classification that I think most of you are familiar with of gastric varices. And I'm going to go through it with you and show you the words Prof. Saharan used to describe these entities. So type 1, he used the British spelling. So esophagus is spelled with an O. So type 1 gastroesophageal varices appear as continuations of esophageal varices and extend for 2 to 5 centimeters below the gastroesophageal junction along the lesser curve of the stomach. And they're only mildly tortuous. So you see in the picture, esophageal varices coming down onto the lesser curve. And actually in our patient, they came about halfway to the incisura angularis. They were large and they were long. And in fact, that still is what we call GOV1. So this is what our patient today had, that I presented today had. GOV2 are continuations of esophageal varices that extend beyond the gastroesophageal junction into the fundus of the stomach. So they're over here on this side of the GE junction. And these are long nodular and tortuous veins continuous with esophageal varices. And so the main difference here is the location. Sometimes, as you all know, these are very large. They look like a cluster of grapes here. Other times they're smaller. Intragastric varices are considered to be gastric varices in the absence of esophageal varices. And depending on location, they can be subdivided into 2 groups. Intragastric varix 1 is fundal varices, just like up here in GOV2, but there are no esophageal varices. And, you know, classically, we said that this often would suggest the presence of regional portal hypertension, of a splenic vein thrombosis, with drainage of the spleen through the short gastric veins and through these collaterals. Certainly, when you see IgV1, you have to consider whether there's a splenic vein thrombosis, but many of these patients also have a generalized portal hypertension. And then IgV2 are so-called ectopic gastric varices, which appear elsewhere in the stomach, not coming down along the lesser curve, not in the fundus, but elsewhere in the body or antrum. And even on Dr. Saharan's original paper, suggesting maybe even in the duodenum. So in his series of 568 patients, these patients, it didn't matter what kind they had, they were treated with esophageal variceal sclerotherapy routinely. It was before the era of band ligation. Now, of course, IgV1 and IVG2 did not get esophageal variceal sclerotherapy. Unless this IgV1, there are no esophagus varices by definition. IgV2, some of these patients also have esophageal varices. And so anyone with esophagus varices received sclerotherapy, no gastric varix treatment unless they had hemorrhage. Okay, so what happened to his patients? Well, first of all, what did they see at baseline in these 562 patients? Well, 20% had primary gastric varices, and they were significantly more common in patients with extrahepatic portal vein obstruction than in patients with cirrhosis. So they're more likely, I mean, a cirrhotic patient can have them, but they're more likely in someone with extrahepatic portal hypertension. The great majority were GOV1. 75% of all primary gastric varices. And these are the ones that come down from the esophagus onto the lesser curve, like the case I presented today. GOV2, 16%, IgV1, 8%. And so about a quarter within these categories, which are the big fundal varices. And of course, GOV2, there's also communicating esophageal varices, not the case with IgV1. And then IgV2, those ectopic gastric varices, were only 1% of all primary gastric varices. So in his series of 562 patients, he only had a small number that primarily had IgV2. And what he found during follow-up, and the follow-up duration is not actually reported in the paper for the whole series, but it appears that it was at least a year and probably 2 years. And what he found is that, and they were sclerosing all the esophageal varices in this cohort. They found that during follow-up, gastric varices had a 50% lower bleeding risk than esophageal varices. So which is interesting. Even though they were sclerosing the esophageal varices, it was still more likely these patients would bleed from their esophagus varices than their gastric varices by a lot. But those who did bleed from their gastric varices bled more severely, they required more blood transfusion, and they were more likely to die. In fact, in this series, 45% of patients with bleeding gastric varices died. Now, you might say, well, why is the bleeding risk higher in esophagus varices than gastric varices? And I mean, the chance of having a bleed is higher within the esophagus. And there's at least one paper that's been done that's looked at the question of what is the distance from the varix lumen to the gut lumen, and has found that that distance is thickest or longest in gastric varices, then in esophageal varices, and the wall is thinnest at the gastroesophageal junction. So that's why oftentimes your mentor, who's may have taught you to do esophageal variceal band ligation, will always say start at the GE junction, because that's where probably bleeding is most likely. Now, of the gastric varices that bled, which ones were most likely to bleed? Well, this is a little complicated, but it's from the same data from this 1992 paper. So on the y-axis is number of patients, and this here is the total patients with gastric varices of various types. And during follow-up, in red, most of them did not bleed. Only a minority in blue bled. But then if you look by type, there's quite a big difference. GOV1, that's these lesser curve varices, most of them did not bleed during follow-up, only a minority. Whereas the fundal varices, GOV2 and IgV1, had a high risk of bleeding. GOV2, it was about 60%. IgV1, it was about 80% during follow-up hemorrhaged. And as I already mentioned, these hemorrhages were more severe and more likely to kill the patient. And then IgV2, the ectopic gastric varices, unlikely to bleed. So you get a picture from this that right away that the worrisome gastric varices are the fundal varices, GOV2 and IgV1. So done in this series, almost 400 of the patients underwent esophageal variceal sclerotherapy. New gastric varices or secondary varices developed in 33 of them. So that's about 9% of the patients who had treatment for their esophageal varices. Most often what developed was IgV2. So that would be this fundal varix up here. What happened to the various types that were primary? Were primary GOV1, that's the varices coming onto the lesser curve, they tended to disappear after esophageal sclerotherapy in the majority, in almost 60%, without any specific treatment. They persisted in about 40%, and most of these they treated with gastric sclerotherapy, and most of those treatments were successful. And there was a later recurrence of GOV1 in only one patient. So most often, these varices disappeared without treatment after treating the esophageal varices. What if there's primary GOV2, the fundal varices? Those disappeared after esophageal sclerotherapy in only 16%. They persisted in the majority. And they developed secondarily during follow-up in 3.5% of patients who, to start with, didn't have them. And it was usually out at 21 months. And 55% of GOV2s bled during follow-up. Hemorrhage was moderate to severe. IgV1, which is again a fundal varix, was associated with severe hemorrhage and never developed secondarily during follow-up. And IgV2, those ectopic gastric varices, developed secondarily in 4% of patients and were associated with severe hemorrhage. And what this means is that most of the time, these actually developed secondarily, because you remember they were present in only 1% to begin with. So these did have a tendency to come up during follow-up. So what can we conclude from this paper? Well, GOV1, the gastric varices often disappear after treatment of esophageal varices. And if they don't disappear or if they bleed, they can often be managed endoscopically. GOV2 is unlikely to resolve after treatment of esophageal varices. That's this fundal varix here. And it can develop secondarily, and it has a high risk of severe bleeding. And IgV1, this fundal varix without an esophageal varix, also has a high risk of severe bleeding. So these are the bad ones. And IgV2 most often develops secondarily and are also associated with severe hemorrhage. So right away here, I hope you see some application to our case from today of a patient hemorrhage who's had a recent hemorrhage and has the large esophageal varices and GOV1. And you can see that perhaps if we can treat the esophageal varices, chances are the GOV1 may not be an issue. Now you might say, well, this was with esophageal sclerotherapy. What about band ligation? And we do have this paper from Korea from 2016, where they looked at 176 patients who had esophageal varices and GOV1. So now in this paper, all of the patients had GOV1. And following variceal ligation, band ligation in the esophagus, the gastric varix disappeared in 65%, diminished in 24%, and were unchanged in 11%. So very similar finding that GOV1 tend to disappear after band ligation of esophageal varices. And they also had this interesting figure, which shows the patients who achieved eradication of their esophageal varices over time. Here's time on the x-axis. And you can see that the curves were very similar, whether you had esophageal varices only or you had esophageal varices with GOV1. So they also found, their paper suggests that when GOV1, we should focus our efforts on treating the esophageal varices. Now, let's talk a little more about what to do about gastric varices, and especially, given what I've said to you, the fundal varices, GOV2 and IgV1. How can we manage these patients? So what about this data I'm now showing you is from a really nice review from the European Society of GI Endoscopy, published just last year in Endoscopy, where they went over all the data about treatment of varices. And they said that for primary prophylaxis of gastric varices, this is treatment of those who have never had hemorrhage, there's very limited data available. We really don't have randomized, properly sized controlled trials to tell us what to do in these patients. But non-selective beta blockers are recommended. And in those with fundal varices, the bad actors who are unable to take non-selective beta blockers, then they said you have a number of options because there's really limited data. One reasonable option is no treatment. Another option could be cyanoacrylate injection, and another would be US-guided therapy, which we're going to talk about in a bit. So, sorry. What about if the varices have bled and it's no longer a question of primary prophylaxis, but we either want to treat this is a fundal varix, by the way. Here's the fundus cap up here. This is a retroflex view, and it's actively bleeding. So what should we do if there's bleeding from gastric varices? GOV1, if they're bleeding on the lesser curve, the consensus is that you should band ligate them, just like you would in esophageal varix. GOV2 and IgV1, then you have a number of choices. One is endoscopic cyanoacrylate injection, but there's a risk of embolism. And I'm going to explain about that in a little bit. Pulmonary embolism. Or you could do something to decompress the whole portal venous system, such as a TIPS, transjugular intrahepatic portosystemic shunt, or a surgical shunt, or a surgical devascularization procedure. Or you could do an interventional radiology procedure, so-called balloon-assisted retrograde transvenous obliteration and Berto, and there's variants, multiple variants that we're going to touch on later. So for fundal varices that are bleeding, you're going to need to do something. And you'll notice that in this guideline, band ligation is not listed here. There are multiple randomized trials for actively bleeding fundal gastric varices comparing band ligation to cyanoacrylate. And in terms of preventing rebleeding, cyanoacrylate does better. So that's why it doesn't appear on this list. IGV-2, the ectopic varices, you really need to do something to try and decrease the portal pressures. And that might be a shunt procedure radiologically or surgically. Now, there are new approaches to fundal gastric varices, and this is going to be the last thing I talk about today. And they are angiographic, endosonographic, and something called intensive band ligation. And so I want to go through these because I think that they may be relevant to many of us in our practices. So I want to show you how a interventional radiologist thinks about gastric varices. You know, we endoscopists, we think in terms of where it is in the stomach and what the signs are of bleeding. A radiologist thinks about it, how is the blood flowing into the varix and how is the blood flowing out of the varix. And so I'm just going to take, sorry, Getachew? Getachew, can you mute yourself, please? So can the rest of you hear me?
Yes.
Okay, great. So let's take just a moment to look at this diagram, and then I'm going to show you some variants of it. So in light blue is the venous splenic vein and the portal vein. And in, of course, in portal hypertension, there's hepatopedal flow here in the portal vein. And this is the coronary vein, sometimes now called the left gastric vein, coming up here. From the splenic vein, there's a posterior gastric vein, there's short gastric veins, and these different veins may feed into a gastric varix. And then what drains the gastric varix may be, most commonly, this, which is a gastrorenal shunt. And it turns out this is present in up to 80% of patients with fundal varices. So this is very common, this gastrorenal shunt. There can also be a shunt straight over here to the IVC, or there may just be shunts up into the paraesophageal and esophageal varices. Now, this gastrorenal shunt is the reason that cyanoacrylate embolizes, because when an endoscopist injects the gastric varix with cyanoacrylate, it may come this way into the left renal vein, to the IVC, up to the right heart, and to the lungs. And there are multiple case reports from Europe, North America, Australia, saying a fatal cyanoacrylate embolization with injection of fundal gastric varices. And this is how the glue travels. It's interesting, when I talk to African colleagues who inject cyanoacrylate, they say it never happens in Africa. We just don't have this problem here. And I don't think that's true, actually. I think that these shunts are probably very common in Africa also from fundal varices. But most of my African colleagues who inject cyanoacrylate inject small volumes. And so I think they must get embolism frequently, but it doesn't kill the patient, and because it's a small volume. And I looked this week for some study from Africa where they imaged the chest after cyanoacrylate injection to see how often there's an embolism. And I don't think the study has been done. But if we have a colleague on the call from Sudan, maybe they will help me with that in the discussion time. Okay, so now that you understand some of this vascular anatomy, here's how an interventional radiologist will approach these these varices. And there are three main types here that the radiologists have for gastric fundal varices. In type A, the varix is fed from the short gastric vein or left gastric vein, this light blue one. It feeds this large fundal varix, and then its only outflow is the gastrorenal shunt. And this is a very simple situation, one flow in, one flow out. And this is a perfect candidate for this BRTO, for balloon-assisted retrograde transvenous obliteration. And here is an example of that. So in this image, there's an endoscope in, and the endoscopist has large fundal varices that are bleeding, actually. And the endoscopist has put a needle into the varix. But at the same time, the patient is on a angiography table. And here's the x-ray. The angiographer has put a balloon catheter into the venously, into the inferior vena cava, into the left renal vein, and into the gastrorenal shunt. And they're occluding it with this balloon that's inflated with contrast. So they've occluded the drainage from the gastric varix. Now the endoscopist can inject cyanoacrylate and polydocanol, and there's no chance it will embolize because the shunt is obstructed by the balloon. And only after the glue sets up does the radiologist remove their balloon catheter. And in other versions of this, you don't need an endoscope. In other versions, the radiologist, through their balloon catheter, will inject sclerosant or glue or thrombin or something to occlude this gastric varix. So, I'm sorry, there are four types. So that's this one here. And I've just shown you a real life example of how this can be treated with the help of an interventional radiologist. Now, type B is more complicated because what's draining the gastric fundic varix is the shunt, but it also communicates up next to the esophagus. And so what the interventional radiologist will do here is they will put gel foam, they'll embolize the esophageal and periesophageal varices, and that then occludes this shunt, and it turns it into this type A, and then you can treat the fundal varix. Type C is similar, but there's a shunt straight to the inferior vena cava. So you can see here, putting a balloon in this shunt here, you can inject something into the varix. It may still go systemically into the IVC. So here as well, the radiologist will embolize this shunt, this intervening vessel, or occlude it with a balloon to enable treatment of the gastric varix. And in type D, there is no gastrorenal shunt. There's just these collaterals up next to the esophagus. And this would be treated, if it's going to be treated by a radiologist, it would be treated with a TIPS. They would do something to decompress the whole pleural system. We endoscopists might say, oh, this is a perfect case for me to inject glue into this varix without worrying about embolization so much. And that would also be true. Now, this venous anatomy can be sorted out with a contrast-enhanced CT scan. So before any of these fancy procedures are done, a CT with reconstruction will tell you what the venous anatomy is. So in our center in Minnesota, we always get a contrast-enhanced CT unless the patient has a contraindication, so that we can decide, can we go ahead and inject the varix endoscopically? Is it type D? Or do we need the help of an interventional radiologist to occlude this shunt and potentially other shunts before we treat the varix? Okay, so that's the angiographic approach to these lesions. Now, the endosonographic approach to fundal varices is embolization and glue. Coils and glue, and using embolization coils. So these are thin loops of wire with Teflon or nylon attached to it, kind of hanging off, looks like hair on these loops of wire. It comes in various shapes and configurations. And these have been used by interventional radiologists for many years to occlude vessels. They deploy these through a catheter or needle into a vessel, and it causes thrombosis. The coil partially occludes the vessel. These filaments cause thrombosis, and it obstructs the vessel. And here's how this is done by EUS. So in panel A Here's some large gastric varices. This is really GOV2 because it's on the greater curved side of the cardia. And you can see there's some varices over here and over here. There's a big collection of them. And here's what the EUS looks like in panel B. So for those of you who don't do EUS, this black line here is the gastric muscularis propria. That's the outer edge of the gastric wall coming around here. And this is some water in the lumen, this black with some air bubbles. And this is sort of the normal rugal folds of the stomach here. And then here, these are the varices. These anechoic or dark tortuous spaces are the varices. And when the operator puts on some Doppler on it, you can see there's a lot of flow in these varices here on this image C. In image D, the endosonographer has put a needle right into the varix from the gastric lumen. And here you can see a coil being pushed out of the needle into the varix. And often we may put multiple coils through the needle into the varix to fill the varix. And then often after that, we'll inject some glue. And if the coils are already in the varix, the glue tends to stick to the coils and those filaments that come off of it. And so here at the completion, there's not only coils, but this is glue in the varix. And the endoscopist can see if the glue has a tendency to embolize or not. But it tends to stay because the coils are already there. And then this is the final images. Now he puts on the Doppler. There's no flow in this structure. And the varices, they no longer are anechoic. They're full of coils and glue. And then this is a follow-up endoscopy picture some time later. One of the coils is starting to extrude into the stomach, which is fine. You see some little bits of glue. And this is probably still glue and coil that's in the submucosa up here. So this treatment, when it's compared to endoscopic cyanoacrylate injection alone, it's more effective at preventing rebleeding, and it has a much lower risk of embolization than endoscopic cyanoacrylate injection alone. So increasingly for fundal varices, it's the endosonographers that may be treating them endoscopically. And in this case, the endosonographer may not care so much about whether there's a gastrorenal shunt or not. Okay, and then the third thing is that I mentioned, and this is the last topic, is intensive band ligation. And this is especially of interest to me because we don't have a lot of other options in our endoscopy unit here for these patients. Now, as I said, randomized trials have shown that there's more rebleeding after band ligation of fundal varices than after cyanoacrylate. And here's why. Here's a published picture showing one band has been put on a large fundal varix, which comes all the way around here and around here. And the endoscopist here has placed one rubber band on this varix, and it has not occluded the varix. I'm sure there's still flow in this variceal complex. And so I'm worried about how this looks. They reported it because they thought it was very successful. But I'm worried that there's still flow in this variceal complex. And when this necrosis and this band falls off in a week or so, that maybe there'll be more hemorrhage from this. So this is why I think often band ligation does not perform as well as cyanoacrylate. But here's this very interesting paper from Korea where they describe intensive band ligation of these varices. So here's one of their patients, active bleeding from a gastric varix. This is GOV2. It's on the greater curve side. This is a varix. This is. The lesser curve here would be up off the screen. And this is during the initial endoscopy. They put 6 bands on the bleeding site and then on multiple other sites. And you might say, wow, that looks pretty intensive. It really looks like they've banded these gastric varices. But no, this is not what they call intensive. So here's a follow-up endoscopy a couple of weeks later. And they said, oh, there's still varices here. This is still really a varix. It's not as large as it is here. And this and this. So they have a technique where they put between 15 and 25 bands on this area to treat the gastric varix. And here now is the follow-up endoscopy, and they're satisfied. They said now there's no gastric fundal varix. So how do they put all these bands? Well, here's how they describe it. The endoscope was inverted at the fundus, and the varices were intensively ligated around the cardiac orifice in a U-shaped pattern. The first row of ligation was performed adjacent to the cardiac orifice and usually consisted of 2 to 5 bands. The second row was parallel to the first row with no gap. In other words, the vascular clusters were in close contact with those of the first row after ligation. Next, ligation continued toward the dome of the fundus until all visible fundal varices were fully and completely ligated. And again, so that's this panel D here. This is what they call intensive band ligation. And well, how did they do? They published a retrospective cohort study of 79 patients who were hemorrhaging from fundal varices. This is actually, in the world of fundal varix treatment, a large series. And the rebleeding and 1 year mortality rates were similar between groups who got cyanoacrylate and those who got this intensive variceal ligation. But the outcomes after 1 year favored the ligation group, actually. And the adverse events were similar between groups, so sorry. They were transient fever or pain, nausea, heartburn, none of these requiring intervention. So I think this is really fascinating because many of us on this call have band ligators. And we deal sometimes with patients with gastric fundic varices where we don't have a lot of other choices. This actually came up just about 4 hours ago in the St. Paul's endoscopy unit again. We had a patient actively bleeding from a GLV2. And so I think that this is a fascinating option for us. Now, one thing to say about this is that you can use a banding device that has a larger chamber because many of these gastric varices are large. And so here I'm comparing 3 kinds of band ligation caps. This one is at the top is the standard esophageal band ligation cap from Wilson Cook. And you can see there's 6 bands on it and just a narrow little bit of cap sticking beyond. And so this is the chamber into which you suck up the varix with suction. This is also made by Wilson Cook, and it's called a large capacity cap. And you can see here there's the same 6 bands, but the cap extends much further. So this is a much larger space, and you can suck more tissue up in here to band it. And in fact, they describe using a large capacity cap in that Korean study. And this is what I've done multiple times in the past, and indeed today, to treat a bleeding fundal varix during endoscopy. So what this is it's 2 standard caps, one intussuscepted into the other. So this is a standard band ligation cap, just like this one, with no bands on it. And then this cap has been fixed onto it firmly and pushed on really firmly, and the string comes through both caps. And this gives you an even bigger chamber in which you can suck something to band ligate it. The main risk with this is you will suck up the whole gut wall, which you don't want to do. You don't want to necrose a hole in the whole gut wall. But in fact, when you do this, unless for gastric varices, I personally have never seen that happen because gastric mucosa is thick and it's mobile. And if it's a large fundal varix, you can suck it in here and it will even hit your lens. The smaller fundal varix we treated today came to about here. And then so we could see some empty space and we banded it and the result was quite nice. So I'm going to stop my presentation here and invite questions. Haile Mikhail, maybe you can moderate.
Yeah, Prof, that's really interesting and practical for us because we all face either a combined one or isolated gastric varices, and we don't have options, as you said, cyanoacrylate. So banding and 2 banding are also one option probably that we can use, and probably also utilizing the MDT with the radiology might be important. And also you showed us the risks of embolization. There are some questions coming here. Before that, the case that have been presented by you and the options which have been given. So it looks the different options work, like we can just leave because the patient can't survive with less bleeding, or which option are you recommending us at last? So each options had been discussed well.
Okay, so first I'll touch on Tinsei's comment, which is very relevant about the case. Yeah. She said, since they were GOV1, varices on the lesser curve of the stomach, we banned both gastric and esophageal varices. And I think that's very, very appropriate, Tinsei. I think that it's interesting to know, though, that most often, if you just ban the esophageal varices, the gastric varices will disappear. So over time. So
yeah, thank you for presenting that data. I actually didn't, because we typically, I mean, these ones look like you said it was extensive, extending to the incisura, so that probably would have been very difficult to do. So it was very interesting to see the data that they can actually regress with the esophageal banding. And I guess your point is, if they had been bleeding GOV1, then you would have banned it, but because the red well signs were the esophageal, then that was an adequate treatment.
Yeah, they were both large. And so a definition of a large gastric varix, many people would say 10 millimeters or more, whereas in esophagus, we say 5 millimeters. But yeah, but I think that it's not unreasonable, especially if you have lots of bands, to go ahead and band along the lesser curve too for GOV1. It's fine. But for fundal varices, my view is that for GOV2 or IGV1, the fundal varices, what's going to threaten to kill that patient is their fundal varix. And so I would really try and direct some treatment at that varix. And it may be if they're hemorrhaging and you don't have a lot of options, your only thing at the time is to band ligate it. But then I would say, don't just put one band. Just get to work on that thing and really band it like that the Koreans did in that picture, and try to ligate it enough that you feel you've interrupted the flow in the varix, or
It's
do nothing.
Yeah, for nothing. Technically to ban fundal varices, because I've never seen that actually. Is it done in retroflexion, or do you do it in forward?
It's all in retroflexion. And the difficulty when you use the 2-cap method is that you have tunnel vision. You're looking down this very long thing, twice as long as a standard banding cap. And it can be hard, like today, the patient is actively bleeding. It's hard to see. You have to sort of persist and wash a bit and suction and finally get a glimpse and then suck the thing into that big cap. But actually, the double cap helps in retroflexion because it brings the tip of the cap closer to the cardia. Sometimes in retroflexion, it's hard to get the tip of your scope right against the GE junction. And so actually the double cap is very helpful in retroflexion for banding. Now, Pantong, Mark mentioned thrombin, and thank you for mentioning that, Pantong, Mark, because it is. So there are increasingly papers suggesting that it may be easier and safer to inject thrombin into these gastric varices than to inject cyanoacrylate. The thrombin, forms a thrombus there. It can still embolize, and it can still cause pulmonary embolism. So some of the safety issues are still there. But it's much easier to use, and you don't have to worry about the thrombin wrecking your endoscope the way you have to worry with cyanoacrylate. So yeah, increasing, and there's a couple of comparative papers now suggesting the outcomes are about the same with thrombin injection as with cyanoacrylate. I myself don't have experience with it. Does anyone on this call have experience injecting thrombin? If you do, we'd love to hear about it.
Yeah.
Okay. Then there's a question from Jonas. Shall we worry worsening of small gastric varices while eradicating esophageal varices? And this is a common concern. If I treat the esophageal varices, the gastric ones will get bigger and they will bleed. But Prof. Saharan's data suggests that if it's on the lesser curve, you don't need to worry about that. That most of those will actually regress or disappear over time. Not all, but most. If it's a fundal varix, you can go ahead and treat large esophageal varices, but you need to have a plan of what to do about that fundal varix, because it may hemorrhage severely and it has a high risk of hemorrhaging, and it may kill the patient. So especially in someone who's had a hemorrhage, I would advocate something needs to be done for that gastric fundal varix. And, in a limited resource setting, especially if the patient has a normal liver and it's pre-hepatic portal hypertension, maybe there's a surgical solution for some of those patients. Maybe this band ligation, intensive band ligation is an option. Maybe it's inject cyanoacrylate, but I would say, think about getting a CT first and see if that gastrorenal shunt is there. Question about hemospray. So that is also a good question. It's been tried. The ESGE consensus paper from last year did not recommend use of hemospray for treatment of either esophageal or gastric varices. But I don't know if there's any new information. I would doubt that that it would be anything but a temporizing measure. Eskinder, thank you for your comment. And then here's a good question. How about a heater probe for actively bleeding gastroesophageal varices? I have not seen that reported. A heater probe is a form of a bipolar probe that heats and cauterizes tissue. And so I would not be enthusiastic about that for any varix, because I would fear it would just burn a hole through the mucosa into the varix, and that I would have a really massive subsequent hemorrhage, exsanguinating hemorrhage from that intervention. So myself, I would not do that. I'd be interesting to hear if you have personal experience doing that. But it would worry me. Our colleagues in Nigeria have talked about using 50% dextrose, and there are a few studies also. That's interesting. I don't know about that. Pentong, Mark, do you want to comment on the technique and on the outcomes?
Okay, yeah. So personally, I don't have experience, but we have this patient currently on the ward whom we're trying to stabilize, hopefully tomorrow. He's got a GOV2 as well, and we've been wondering what to do with him. And so we just brought up the case among the gastroenterologists, and a few people told us that in the absence of cyanoacrylate, they've tried to inject with 50% dextrose, and they've been able to achieve some form of sclerosis of the vessel. And then, because it's strange to us, so we try to look up literature, and there are a few people that have reported that they've also used 50% dextrose as well. So I thought to mention it here and see if anyone else also has experience. So essentially, I spoke to one of the doctors who have used this technique, and he says they put a sclerotherapy needle submucosally and then inject the 50% dextrose. And yeah, they've been successful so far.
So is he injecting into the varix or next to the varix?
Next to the varix, yes.
Oh, interesting. And what is the theory about why it would work?
Well, I mean, I think because 50% dextrose is hypertonic in many ways, so it sort of forms like an inflammation around the vessels and eventually causes sclerosis.
And did these papers include any follow-up to see if the gastric varices were eradicated or gone?
Okay, no, so they didn't even publish that. So it's just, I mean, we were really wondering what to do, and that was what they told us. So that's why we were really looking forward to hear what else can we do. But this intensive banding looks like something that we'll try to have a patient. So I'll post a picture on the WhatsApp group of the patients.
In many ways, I would say the radiologic approaches that I showed are the most elegant approaches, because they're really taking the venous anatomy into account, what flows in, what flows out, and treating it comprehensively. But for many of us, that simply isn't an option. So we don't have that available. And then if you have EUS, I think this is, because I've done this by EUS, and it's very satisfying, and you treat the whole complex of gastric varices at once, and you see what you're doing. But again, many of us don't have that available. Now, and I think it would be very interesting to see some follow-up data about the dextrose idea, because if it works, that would be very helpful to know for many of us. You probably need a larger gauge sclerotherapy needle to inject such a viscous solution. I don't know if it would go through a 23 gauge needle, for instance, but we'll be interesting to hear more from you about what you do. Can we band ligate IgV1 if not bleeding if we don't have other treatment options at our site? I think that you can, but the consensus is if it's primary prophylaxis, you should just use beta blockers. You should not be intervening if the thing has never bled. If it's hemorrhaged, then I think you could take the Korean approach and try this intensive gastric ligation. And personally, I would do it with some sort of larger cap on the tip of the endoscope, either a large capacity cap or a double cap. But that it's because these varices, these fundus varices, once they bleed, the mortality is high. So the patient, you want to do something to treat the bleeding and prevent rebleeding. Then there's a question from Sawale. How about direct link to surgery for gastric varices, devascularization? We frequently see patients with such varices and no cirrhosis. Yes, and I think I mentioned that briefly, but I thank you for mentioning that again, Sawale. If the patient has normal liver function, they're not cirrhotic, their FibroScan is normal, then that makes a lot of sense to me, because they're likely to do well with surgery, low morbidity, low mortality. The surgeon will essentially interrupt all those vessels that were shown on that sketch, the coronary vein, the posterior gastric vein, the short gastric veins. They'll devascularize all of that. And so they will deprive the gastric varix of its perfusion, and it will shrink and go away. And so I think that's a very reasonable solution. It's even more important to consider surgery in IGV-2. We didn't talk about much about that because it's so uncommon, but actually in the last 2 weeks at St. Paul's, we've seen 2 cases now of IGV-2. One of them had big duodenal varices also. And these were, again, patients with extrahepatic portal hypertension. And so in IGV-2 and in duodenal varices, I think you really want to do something to decompress the portal venous system. You can band or inject gastric varix, but if it's IGV-2, they'll just pop up somewhere else in the stomach. Or as I say, you'll see them in the duodenum next. So I think those patients really need to have something to decompress the portal system. In a case of gastric varices and big esophageal varices, do we ban for esophageal varices and put on NSBB for gastric varices? I think it depends, Mifta, on what kind of gastric varix. If it's GOV1, well, first let me say that anyone who's bled from esophageal varices, the best treatment is to combine beta blockers and band ligation. So it's easy to say, yes, of course, if there's gastric varices, we should do that too. I think if it's GOV1, that may be all the patient ever needs. If it's GOV2 and there's a large fundus varix, I would be worried that they still are at significant risk for hemorrhage from that varix. And so if they've had a hemorrhage already, even if it was from the esophagus, I would consider my options for what to do about that large gastric fundal varix. And we've discussed the options here today. If they're small gastric varices, everything I presented today about intervening was based on large gastric varices. So if they're small, less than 10 millimeters, the risk is probably not so high, and observation beta blockers might be fine. What about splenectomy? Splenectomy makes the most sense if it is regional portal hypertension. And what I mean by that is that there's portal hypertension in the splenic outlet, but the splenic vein is obstructed. And so the portal vein pressure is normal, the superior mesenteric vein pressure is normal. In that patient, who most often has some pancreatic lesion or chronic pancreatitis, and they've thrombosed their splenic vein, then splenectomy cures them of their varices because there is no more input to the varices. So other than that, splenectomy doesn't have a big role in treatment of generalized portal hypertension. And, you know, there are surgeons who will remove the spleen, say, I'm removing part of the blood flow into the portal venous system. But and you have to go back to the 1960s and 70s to find surgical papers about this. But none of it is very convincing. I've looked at some of those papers. None of it is very convincing about the benefit of splenectomy. So I'm not convinced about that part of the surgical intervention. Then there's a question, no prophylaxis of fundal varices endoscopically. Yeah, so you'll remember, what about if it's primary prophylaxis and there's a large, can you still hear me? Hi, Mikhail? Yeah, okay. So the ESGE says you case by case decide, no treatment, inject it, use EUS to treat it. You could use the radiologic methods to treat it. It's really your judgment call. And data, no one's done a public or study to compare beta blockers alone to some intervention, such as the best ones I've described, for primary prophylaxis of large fundal varices. So you have to decide. To me, if it's a really large fundal varix, I'm worried about it. I'm worried the patient will exsanguinate. And I'm an interventionalist, but I would favor doing something primarily, but I can't base that in great data. Secondly, if fundal gastric varices are present, perhaps better to get CT to assess shunts. Yeah, I agree. If you have the option of understanding the venous anatomy of the gastric fundal varix and designing your treatment to fit the venous anatomy, that makes a lot of sense. It's hard to argue with. We don't yet have, for instance, comparative prospective trials of the EUS approach versus the radiologic approach. I hope somebody is doing that study, because that would be really interesting. But until then, I think both of them seem acceptable. But understanding the venous anatomy is important in all of our settings, because if there's a gastrorenal shunt from a fundal varix, I'd be really nervous about using cyanoacrylate in that patient myself. I think we're about done, Haile Mikhail, and we're about done with our time too. It's perfect.
Professor Mark, this is really one of the very practical sessions for us. It's very helpful. This is something that we apply after the lecture. I think that's my idea. I just want to hear some experiences from the Sudan Bleeding Center, and we have Hala and Salma here. Probably if they can tell us their experience of such banding or management of the gastric varices or combined one. I think we have Hala here and Salma, if they can.
Yes, that would be great to hear from them. I agree.
Okay.
Hi.
Hello, Hala.
Hi, hello. Hello, everyone.
Yes. Yes.
Fine. Fine. How are you?
Okay.
Yes, I want to comment that we might not see a lot of, or maybe a lot of cases of embolization of cyanoacrylate because we use very small amount of cyanoacrylate injection. We use maybe 1 ml injection, and we inject in a frequent session, more than giving a very large volume. And recently, we are faced by more cases of gastric varices. And it might be due to, we think that it might be due to eradication of esophageal varices. I think one of our fellows started to collect data of occurrence of gastric varices in a patient with eradicated varix. But I don't know if he complete his analysis or so. So we have a lot of cases of gastric varices. We use only cyanoacrylate. We don't have intervention radiology. And we see a lot of cases pleader, most of them secondary to periportal fibrosis, portal hypertension due to periportal fibrosis due to schistosomiasis, more than patient with liver cirrhosis.
Thank you for commenting, Hala. Go ahead.
Yes, when we use, before availability of the bands, we use sclerotherapy for the esophageal varices. We use, we inject the varices by the ethanolamide oleate 5%. But when there is available bands, we use the bands more than the sclerotherapy. Although some of our doctors, mainly the surgeons, they like the sclerotherapy in treating the bleeding esophageal varices, more the band ligation. We see sometimes the complication of mediastinitis secondary to ethanolamine oleate sclerotherapy. That's not so frequent. We also, when we use sclerotherapy for the bleeding esophageal varix, we use a small amount, and the surgeon with a strong heart, they use a very large amount, maybe up to 20 ml ethanolamine oleate. So the problem that when the patient comes for follow-up, an elective follow-up, the varix will be very stiff and it will be very difficult to suck the varix for the rest of sessions of the band ligation.
Okay.
This is regarding the esophageal varix.
Okay. Thanks so much, Anna.
The
Yeah, please proceed.
yes, thank you.
Go
Yeah, the
ahead.
histoacryl is very expensive and not available. The histoacryl is not available and expensive. We use only 1 ml. We inject only 1 ml in the varix, and we do a frequent session for injection.
Okay.
Do you mix it
Yeah.
with polydocanol, or you just use straight cyanoacrylate?
We don't have Libidol. Previously, they use sesame oil, but when I was trained, they only they only use distilled water first, and very rapidly they use the cyanoacrylate, and then followed by the distilled water. Only they give it very quickly. They don't use any Libidol.
You say you don't see embolism, but my guess is you have embolism all the time, and that is just subclinical.
Subclinical.
And so it would be very interesting from your center to have some study of chest imaging in these patients who've had multiple sessions. I realize it would probably take a non-contrast chest CT, but I would be willing to bet that most of them will have multiple pulmonary emboli of glue. It's just that you've used small volumes, so it has not killed them. But I might be wrong. Maybe in your setting, there doesn't embolize. Maybe these gastrorenal shunts are not as common in your setting. I don't know.
Yeah.
Okay, it might be.
Yeah, further studies are important. Probably some prospective ones to see such kind of studies. And sometimes this needs like prospective follow-up study, what happened subsequently. I think that's very important to have. I think
Yes.
the time is, but if there are any additional comments from the groups that you share us, otherwise the time is one limiting factor for us. And don't forget to fill the feedback link. That's very important. Professor Mark, you are giving us very informative talk. All of us thank you for such very practical presentation and showing how to do with the available resources also. That's very important for us. And then we need to have further studies, including like Pantok has brought some interesting ideas from available resources, like 50% dextrose, probably looking such data and research will be very important for us for resource limited setting. Prof, do you have anything to add?
No, that's great. We'll see you all in 2 weeks.
We'll see you all in 2 weeks with another presentation, probably case presentation. And if you have cases, please send us your cases. If you want to present, send us your cases to Prof. Mark or to me. And yeah, join us in 2 weeks' time.